Enter station and wash your hand with alcohol gel. Introduce yourself to the patient, explain your role, what you are about to do, and ask for their consent. Note that it's important to have a chaperone present in the room for an intimate exam. However, some patients do refuse the presence of a chaperone, and it's important to document such. Before you proceed with the abdominal pelvic exam, check the patient's vitals at the end of the bed and perform a full cardiorespiratory examination. Patient looks well, is lying in bed comfortably and no obvious signs of distress. Patient does not look pale, there is no sign of edema in the face or legs, and there is obvious distension of the abdomen consistent with pregnancy. On closer inspection of the abdomen, there is no linea nigra, no striae gravidarum, and no scars from previous surgery. Also no masses, and the umbilicus is everted, which is normal. Feel for the symphysis pubis. Place the tape on the abdomen with the numbers facing downwards. Then, place the tape on this point and extend it across the abdomen. Using the ulnar surface of your left hand, feel for the fundus and mark where it's felt on the tape. Lastly, flip the tape over to get the accurate measurement. Step 1. While facing the patient, palpate the patient's upper abdomen with both hands. An obstetrician can often determine the size, consistency, shape, and mobility of the form that is felt. The fetal head is hard, round, and moves independently of the trunk, while the buttocks feel softer, are symmetric, and the shoulders and limbs have small bony processes. Unlike the head, they move with the trunk. Step 2. Still facing the patient, palpate the abdomen gently but with deep pressure using the palms of your hands. First, the right hand remains steady on one side of the abdomen, while the left hand explores the right side of the patient's uterus. This is then repeated using the opposite side and hands. The fetal back will feel firm and smooth, while fetal extremities should feel like small irregularities and protrusions. Step 3. Move to the right side of the bed facing the patient's feet. This step is used to locate the fetus's brow. The fingers of both hands are moved gently down the sides of the uterus towards the pubic area. The side where there is resistance to the descent of the fingers towards the pubis is greatest where the brow is located. Pollick's grip. This step is used to assess fetal engagement. Grasp the lower portion of the abdomen just above the pubic symphysis with the thumb and fingers of the right hand. The findings of this step should be the opposite to the ones found on the first maneuver. If the head is not actively engaged, you will feel the baby's head rocking back and forth. Note that this maneuver can be uncomfortable for the patient. Make sure to comment on lycra volume as well as the lie, presentation, where the back is, and how much the head is engaged. Example, on palpation there was found to be a longitudinal lie with cephalic presentation and the head is engaged, and lycra volume is normal. Place the panade on the anterior part of the shoulder of the fetus. Once placing the panade on the abdomen, secure it with your air, as holding the panade with your hands can distort your findings. In a cephalic presentation, the head would be right or left lower abdomen. You should ideally listen for 15 seconds while palpating the patient's radial pulse. This is to differentiate the fetal heart rate from the patient's. The normal fetal heart rate should be between 115 and 160 beats per minute. Thank the patient and help them get dressed.